Welcome to the Funnel Effect. Today we are undertaking, well, a really high-octane, highly specialized deep dive. We're going right into the heart of interventional cardiology. Our mission today is pretty crucial. It's to gain an A to Z understanding of something called rotational atherectomy, or RA for short. This is a sophisticated, you could say high-stakes cardiac procedure, and it's designed to conquer really the biggest roadblock faced in the modern cath lab: severe coronary artery calcification, or CALC.
Exactly. And this isn't just, technical jargon for the specialist. This is absolutely essential knowledge for anyone tracking developments in cardiovascular technology. We based our discussion today, synthesized it really, from a pretty definitive procedural roadmap. It's a review article called Rotational Atherectomy, A to Z. It's authored by Jin Jung, MD, PhD, and Sung Ho Her, MD, PhD. It's from the Department of Cardiology at St. Vincent's Hospital, College of Medicine, the Catholic University of Korea. So essentially, this is the expert's guide to dealing with these incredibly challenging lesions.
And the importance of mastering this procedure, it's skyrocketing, isn't it? I mean, as our population gets older and medical advances mean more people are surviving longer, often with complex conditions, well, the sheer number of percutaneous coronary interventions, PCIs, being performed on patients who have this severe TAC, it's growing exponentially.
That really is the core issue, yeah. Severe CAC isn't just, a tricky spot in the artery. It can be a procedural killer. When you have this dense, rock-hard calcium lining the inside of the coronary artery, it creates several, potentially catastrophic failure points for a standard stenting procedure.
Okay, so what are those specific failure mechanisms? Why can't we just, say, use a high-pressure balloon to crack that calcium open?
It's because calcium is fundamentally inelastic. It doesn't stretch. So if you simply tried to balloon it aggressively, you risk damaging the vessel itself, causing trauma, or maybe more commonly, the calcification just plain prevents the balloon, and therefore the stent delivery system, from even reaching the target site. It's like hitting a brick wall. But let's say you manage to muscle the stent through anyway. Even then, the hard calcium can cause, polymer damage to that important drug-eluting coating on the stent. And maybe most critically, it prevents the final stent from expanding fully, properly.
Really? So the stent is supposed to push the artery open and hold it there, act like a scaffold. But this hard calcium stops the stent structure from reaching its final optimal diameter. That's what you call stent underexpansion then.
Precisely. And, in this era of really sophisticated drug-eluting stents, stent underexpansion is arguably the single biggest mechanical reason for restenosis. That's the re-narrowing of the vessel after the procedure. And that leads directly to failure, maybe urgent repeat procedures, and definitely poor long-term clinical outcomes for the patient. So the data really makes the conclusion stark. Overcoming severe CAC is absolutely crucial for the procedure to succeed and ultimately for a better patient prognosis. RA isn't really a luxury item anymore. It's becoming a necessary foundational step in many complex cases.
Okay, let's unpack the science behind this a bit more. If we accept that VARI is, as you said, rock hard and inelastic, how does a rotational atherectomy actually manage to physically remove that blockage? How does it create a channel without, ripping up the healthy elastic vessel wall right next to it? What's the core mechanism?
It relies on a principle that's actually quite elegant in its simplicity. It's called differential cutting. Imagine a tiny high-speed burr. It's made of nickel, and it's tipped with thousands of microscopic diamonds. We're talking really tiny, like 20 to 30 microchrometers in size. This burr is driven by a gas turbine, spinning it at incredibly high speeds.
High speed plus diamond dust. Okay. But why is it selective? How does that rotational force know the difference between the rigid calcium and the delicate elastic artery tissue?
It's all down to material properties. The inelastic hard tissue, that's the calcium plaque, you can't really move away from the abrasive burr effectively. So it's forced to yield, basically. It gets filed down. But conversely, the healthy arterial wall, because it's soft and highly elastic, it just flexes away from the burr as it spins past. The source article gives a really good analogy. It's like filing your fingernails with coarse sandpaper. You remove the hard, inelastic nail, right? But you stop, or the effect lessens dramatically when you hit the soft, elastic skin underneath.
Huh. That makes the procedure sound, infinitely less terrifying. It's more like an act of precise filing, not aggressive drilling or scraping.
Exactly. It's targeted microabrasion. But then there's the next logical question, isn't there? If you're filing down calcium, that material, that debris, has to go somewhere. And this leads us to the second really important pillar of RA safety.
Right. What happens to all that material that's filed away? Where does the dust go?
Well, the rotational speed and the specific size of those diamond particles are engineered very carefully. They break down the atheroma components into fantastically tiny fragments. We're talking particles around 5 micrometers in size. And this size is absolutely critical
5 micrometers. Okay. Why is that specific number so important for the patient's safety?
because 5 micrometer particles are actually smaller than red blood cells. So when these tiny microdust particles are released downstream into the blood flow, they're small enough to pass safely right through the distal coronary capillaries and the microcirculation without causing an obstructive embolism, a blockage. Once they're out in the larger blood supply, they're simply and safely eliminated by the body's natural waste removal system, the reticuloendothelial system.
So the body just naturally clears away this microdust created by the procedure. That sounds like the real safety engineering breakthrough. It ensures that modifying the lesion locally doesn't result in some kind of catastrophic blockage further down the line.
It absolutely is. We modify the lesion right where it needs it, locally, and then we rely on the body's own physiological systems, its physics really, to clear the waste systemically. Pretty clever.
Let's look at the history here a bit. If differential cutting is such a great principle, why did RA's use actually decline for a while after it was first introduced, maybe decades ago?
Yeah, that's a good question. It wasn't really the cutting mechanism itself that failed back then. It was more about the follow-up strategy. Originally, RA was used primarily for quite aggressive plaque debulking, trying to remove as much plaque as possible. However, some early important studies, specifically the ERBAC and COBRA trials, they showed pretty high restenosis rates following RA procedures at that time.
And what was missing back then that we have now? What changed?
Well, the big thing we lacked was modern, sophisticated drug-eluting stents. The early strategy was basically debulking with RA, followed by either just a basic balloon angioplasty or maybe a bare metal stent. The aggressive debulking sometimes caused its own injury to the vessel wall, and without that polymer and drug coating you get on modern stents to prevent smooth muscle cell proliferation. Well, the vessel just re-narrowed relatively quickly.
Ah, okay. So the failure wasn't RA itself, but more the lack of a complementary technology, like the right kind of stent, to sort of lock in the success afterwards. But now it seems like it's back in a big way, the resurgence you mentioned.
Absolutely. The resurgence is really driven by two main factors. First, the increasing prevalence of these really challenging cases, severe CAC, often in an older patient demographic. And second, the evolution of the RA device itself. It's become safer, more refined, and crucially, it's now used alongside the evolution of modern stenting technology. They work together now.
How common is RA now if it's so essential for these tough cases? Is it becoming, a routine procedure?
Well, the prevalence still varies quite a bit depending on the center and the country. Generally, it's cited as being used in somewhere between 1% and 4% of all PCI procedures globally. But, and this is the key point, this frequency is definitely expected to climb steadily. Why? Because the trend is towards tackling more high-risk, complex procedures. And these are the very procedures where RA is often the necessary starting point, the enabling technology.
It really sounds like it's quickly transitioning from being seen as a specialty tool to more of an essential mastery for interventional cardiologists.
Exactly right. And that leads us to a critical challenge that the source article highlights. There's still a relative lack of standardized protocols and systematic education surrounding RA because the success of this high-precision technique is so heavily dependent on the operator's training, their experience, their feel. This kind of detailed A to Z review becomes absolutely essential for closing that knowledge gap across the cardiology community.
Okay, so we're moving from the why and the how of the mechanism into the really practical application side. Before the procedure can even be set up, the operator has to make some very precise decisions about patient indication and, of course, equipment selection. Let's start with patient selection. When is RA definitively indicated? When do you say, right, we need to use this?
The overarching indication is pretty clear. RA is generally required for severely calcified lesions when you're preparing for angioplasty or stenting. That's the headline. But the specific indications, the triggers, are often based on practical failure points you encounter with standard equipment.
What are those failure points then? Give us the thresholds, the decision points.
Okay, so you look for resistance when trying to use basic tools. For instance, if you can pass a very small balloon, say 1.5 millimeters or smaller, through the lesion, but you absolutely cannot pass anything larger than a 2.0 millimeter balloon despite trying, that's a pretty strong indicator RA might be needed. Similarly, if your standard imaging catheters, like an IVUS catheter or maybe even just a microcatheter, fail entirely to cross the lesion, if they just won't go through, then RA is the next logical step.
And you mentioned IVUS, intravascular ultrasound. That's often considered the gold standard for really seeing inside the artery, right? What specifically does IVUS show that might flip the switch, making RA seem mandatory?
Right, IVUS gives you that cross-sectional view. If the IVUS imaging shows superficial circular calcification, so calcium near the surface that covers more than 270 degrees of the vessel circumference, well then RA is usually deemed necessary. That amount of circumferential hard calcium pretty much guarantees that standard balloon dilation just won't be sufficient. It confirms that if you try to skip RA in that situation, you're almost inevitably going to end up with incomplete stent deployment and, down the line, restenosis.
That sounds like the definitive diagnostic trigger. Okay, now for the red flags. What are the absolute contraindications? When must you absolutely not use this device?
There are a few clear stop signs. Firstly and fundamentally, if the guide wire, and remember, this needs the specialized rotowire, if that wire cannot pass through the lesion at all, you simply cannot proceed with RA. You need that pathway established first. Secondly, RA is absolutely contraindicated in saphenous vein graft stenosis. Vein grafts behave very differently to native coronary arteries. The material is different, and the risk profile for RA is just too high.
Got it. And what about relative contraindications? Situations where you might proceed, but with extreme caution, perhaps requiring surgical teams on standby.
Yes, there are several situations where you need to be extra careful. For example, if the lesion is located in the patient's last remaining functional coronary vessel, obviously, the consequences of any error there are much higher. Also, if there's already expensive coronary dissection present before you even start, or if the patient has thrombotic lesions clots. Or, importantly, if they have severely depressed left ventricular function, typically defined as an ejection fraction below 30%. We also proceed very cautiously with particularly long lesions, say greater than 25 millimeters, or those with very sharp bends, acute angles greater than 45 degrees. And critically, as you mentioned, you should really not be performing this type of high-risk procedure without immediate surgical backup available, just in case of major complications like perforation.
It really underscores that preparation dictates success here. Okay, moving on to the equipment itself, let's start with the guiding catheter. Why is the selection of this particular catheter so important?
The guiding catheter is crucial because it provides the necessary support and acts as a conduit for the whole high-speed burr system. Historically, some operators experimented with catheters that had side holes, but the critical requirement now, the standard of care, is coaxial engagement. This means the catheter needs to line up perfectly straight with the target vessel opening.
And why is that coaxial engagement considered non-negotiable now?
Primarily because it maximizes backup support. Think about it. You've got a high-speed rotating burr. There's friction as it pushes through hard calcium. This requires massive, stable external support from the guide catheter. Coaxial alignment also minimizes what's called guide wire bias, ensuring the burr stays centered in the vessel. This reduces the risk of eccentric ablation digging into one side, which can lead to injury or the burr getting stuck.
And the size relationship between the burr you choose and the catheter you use is very precise, isn't it? If you don't match them correctly, you can run into problems like excessive friction or poor imaging. What are the general rules for sizing?
Yeah, they need to match up. Generally, for the smaller burrs, like the 1.25 millimeter, 1.5 millimeters, and 1.75 millimeter sizes, a standard 6 French or 6 FR, guiding catheter usually works. However, there's an important jump due to the internal diameter constraints. A 2.0 millimeter burr absolutely requires a 7 FR catheter. You can't use a 6 FR. And then any burr size 2.15 millimeter or larger demands at least an 8 FR catheter.
And the source paper reminds us that, annoyingly, the actual internal diameters can vary slightly between different manufacturers, which can affect these rules slightly.
Exactly. That's a really practical point. For example, some specific guiding catheters, like certain ones from Cordis mentioned in the paper, have subtle differences in their internal dimensions. This might force you to use a 7 FR catheter even for a 1.75 millimeter burr or an 8 FR for a 2.0 millimeter burr, just to ensure you have smooth passage and adequate support. You have to know your equipment.
So what's the practical advice then for an operator who might be facing a particularly tough calcified lesion, or perhaps someone who is still building their experience with RA?
The general advice, and it's sensible, is when in doubt, go slightly larger on the guiding catheter. For example, maybe using a 7 FR instead of the absolute minimum 6 FR for a 1.75 millimeter burr. That little bit of extra space can really minimize friction, ensure easier burr movement back and forth, and importantly, it allows for superior angiography, getting better contrast injection during the runs, which is critical for monitoring what's happening.
Okay, guide catheter sorted. Now for the guide wire itself. the specialized rotowire. We have two main types mentioned, the rotowire floppy and the rotowire extra support. How does the operator decide which one is the right tool for the specific lesion?
The choice really depends on the lesion's anatomy, how twisty it is, and the density of the calcium. The rotowire floppy is generally the initial preferred option for most cases. It's designed to be more flexible, it has a softer tip, and it really excels at navigating tortuous or winding anatomies. This significantly reduces the risk of accidentally injuring the vessel wall as you advance it.
But I guess that flexibility comes at the cost of stability, right?
It does. That's the trade-off.
Yeah.
The limitation of the floppy wire is that it provides less support, and that can become a major problem in extremely dense, heavily calcified lesions or very long lesions, where you need more pushability, more stability to advance the burr through the blockage.
That sounds like where the extra support wire comes in. What makes it different? What gives it that superior stability?
The rotowire extra support is structurally different. It features a longer spring tip combined with a shorter, stiffer, tapered shaft section. This design provides dramatically superior support. It really helps stabilize the burr's advancement, especially through tough calcified segments or highly angulated bent vessels where precise control is absolutely paramount. However, that very rigidity is also its drawback. Its stiffness increases the risk of trauma, potentially leading to vessel injury if you're not careful, especially in complex or severely curved anatomy.
Now, since these rotowires, by design, are relatively stiff and they lack the subtle maneuverability of the standard coronary wires operators use every day, how do they actually ensure the rotowire reaches the ideal position far down the vessel?
Yeah, they aren't easy to steer, so it's usually a pragmatic, two-stage approach. Operators rarely start the whole procedure with a rotowire. Typically, they'll first use a familiar, highly steerable 0.014-inch standard coronary guide wire, one they use all the time to carefully navigate the anatomy and reach the desired distal location, well past the lesion. Once that path is secured, they then perform a wire exchange. This usually involves using either a microcatheter or sometimes an over-the-wire balloon catheter to swap out the standard wire for the specialized rotowire, threading the rotowire down the path already created.
And there's a crucial safety note here in the source about positioning the tip of that rotowire.
Yes. This is a point that absolutely cannot be overstated. You must never place the rotowire tip deeply into small side branches of the coronary artery, nor should you allow it to form loops within the vessel. The visual examples provided in the source material clearly show the potentially devastating consequences. If the rotowire tip gets lodged deep in a small branch, the torque and the abrasive force from the burr's rotation, even if the burr itself isn't touching the tip, can lead almost instantly to coronary perforation. Careful, far distal positioning in the main vessel lumen is the absolute rule.
Okay, finally in this section, let's talk about burr size selection. You mentioned earlier this saw a major paradigm shift driven by clinical trial data. What was the core revelation from those studies, like Stratas and Carrot?
The revelation really shifted the entire strategy. It moved away from the old idea of maximal debulking, trying to remove as much plaque as possible, towards a more nuanced strategy of strategic lesion modification. Previously, the thinking was you needed to create a massive clean hole. But these studies showed that using relatively small burrs, defined usually as having a burr-to-artery ratio of 0.7 or less, actually delivered comparable long-term outcomes. And crucially, they did this while drastically reducing procedural complications compared to using the older approach with large burrs, where the ratio was often greater than 0.7.
So if we don't need to create a huge hole anymore, what is the current recommended target size or ratio?
The current consensus, the sweet spot, is to aim for a burr size that's about 50% to 70% of the reference blood vessel diameter. This gives you a target burr-free ratio typically in the range of 0.4 to 0.6. The goal now isn't to remove everything. It's simply to effectively score the calcification to create a sufficient channel, maybe a critical crack in the calcium ring, that then allows the subsequent high-pressure balloon and the stent to engage properly and deploy fully without being constrained.
It's just enough modification to fracture that rigid casing, essentially. But what's the warning if the operator goes too small, maybe aiming for a ratio below that 0.4 target?
If the burr is too small relative to the lesion's bulk and hardness, it might not engage the calcium effectively. It could just spin relatively harmlessly in the central lumen without creating the necessary fracture or crack. That means the lesion remains essentially unmodified, and you haven't achieved your goal. Conversely, if you're aiming for a ratio at the higher end of the recommended range, say 0.6 or slightly greater, the source highly recommends using intravascular imaging, like ABUS, both before and after the RA run. This helps confirm that the modification is adequate but also safe, preventing potential overablation or creating a deep dissection. So the ratio is really just a guide. The actual degree and the nature of the stenosis, how hard it feels, is the ultimate determinant for the experienced operator.
Right, preparation really is everything in RA. Now that we've covered selecting the patient and the right equipment, we need to move to the really rigid step-by-step checklist. This is necessary to safely operate the high-speed turbine system itself. Could you walk us through the essential steps of system preparation?
Absolutely, and this sequence must be followed meticulously every single time. First, you connect the power source. That's the gas supply hose, which connects to the main console. Remember, the burr is driven by compressed air or nitrogen. Second, you connect the specialized Dynaglide advanced pedal hoses, the ones with the colored connectors. You have to ensure the green and blue ones go to the ports on the back of the console, and the pink one connects to the front port. Third, pretty straightforward, connect the main console power cord and turn the system on.
Okay, that's the primary power and gas setup done. What's next? The monitoring and control connections.
Exactly. Next, you must connect the black optical cable that comes from the advancer handle unit. This plugs into the tachometer area on the console. This is the absolutely crucial link for monitoring the rotational speed, the RPMs, in real time. Without this, you're flying blind on speed. And finally, you connect the gas connection hose that also comes from the advancer mechanism itself back to the console. This ensures the driving gas pressure is actually delivered to the burr via the handle controls.
Okay, console ready. Now, the burr catheter itself needs to be connected to that advancer handle. What's the key caution or warning during this step?
You need to handle the burr catheter connection with extreme care. When you're removing the protective cover that it ships with, you must ensure the flexible catheter shaft is never bent sharply or twisted. The burr catheter contains a very delicate, dedicated central passage for the rotowire. If that shaft gets deformed, even slightly kinked, it can obstruct the wire's movement later, potentially leading to a catastrophic procedural failure, like the wire getting stuck or breaking.
And before that burr even gets close to the patient, there's an absolutely essential pre-procedure safety drill that must be performed every time, the DRAW test. We should really make this memorable for anyone listening.
Yes, this is the mandatory functional check. Think of it as the final systems check before launch. Every letter confirms a vital operational aspect is working correctly.
Okay, let's break it down. Start with D.
D stands for drip. You need to briefly engage the rotation pedal and physically confirm that the cocktail solution, that's the special lubricating and cooling fluid, is being properly expelled from the tip of the burr while it's rotating. If there's no drip, something's wrong and you don't proceed.
Got it. Next up, R for rotate. This is where you set the actual cutting speed.
Correct. R is for rotate. This is where you set the target RPMs, and as we discussed, this is based on the burr size you've chosen. It reflects that balance between needing enough power to ablate and maintaining stability. So for the smaller burrs, typically 1.25 millimeters up to 2.0 millimeters, the rotational speed is set relatively high, usually somewhere between 160,000 and 180,000 RPM. But for the larger burrs, those 2.15 millimeters and bigger, the speed is set slightly lower, generally between 140,000 and 160,000 RPM.
And remind us why the speed is lower for the larger burr.
It's mostly physics. A larger burr simply has more mass. Rotating more mass at those extremely high speeds increases the potential for instability, vibration, and also generating excessive heat, which could cause thermal injury. So the slightly slower speed for larger burrs maintains safety and control while still delivering sufficient abrasive power to modify the calcium.
Okay, makes sense. Then we have A for advancer.
A is for advancer. Here, you must physically test the functionality of the advancer handle itself. Ensure it allows smooth, controlled forward and backward movement of the burr mechanism within the handle. It shouldn't feel stiff or jerky.
And finally, W for wire.
W is for wire. This is where you confirm that the rotowire is locked securely in place within the advancer mechanism during operation. You test the brake mechanism. A slipping wire during high-speed rotation is an immediate recipe for serious complications, like wire fracture or losing distal position.
Okay, DRAW test passed. System checked. We're now moving into the execution phase, the actual ablation inside the vessel. Could you walk us through the initial setup once a system is inside the guiding catheter?
Right, so first, you use fluoroscopy live X-ray imaging to confirm the burr's location. It should be safely parked just inside the tip of the guiding catheter. Then, you typically fix the advancer knob, locking the burr's position relative to the handle when the burr is positioned about 2 to 3 centimeters inside the guiding catheter tip. With the rotowire itself fixed distally, you then gently advance the entire system guide catheter advancer burr forward towards the lesion under fluoro guidance.
And when do you release that advancer knob and actually begin the cutting or ablation run?
As the burr visually approaches the start of the lesion, you can see it on the fluoro image, just proximal to the blockage. That's when you unfasten the advancer knob. And simultaneously, the operator might slightly retract the rotowire just a tiny bit. This ensures there's maximum slack in the wire system, preventing tension on the wire during rotation.
What are the critical limits on the burr's movement during the actual ablation run? How far should it travel?
This is important for control. The burr should really never move more than about 3 centimeters forward or backward within the artery during any single ablation run. Keep the movement short and controlled. The advancement needs to be steady, gentle, and critically, it should only meet with weak resistance as it passes through the lesion. If you feel major resistance like the burr is stalling, you stop immediately.
And the actual movement technique is often described as the pecking motion. Can you describe what that looks like?
Yeah, it's an incremental advance and retract movement. The burr is rotated while making these short, controlled back and forth movements, literally like a bird pecking at something. You advance a little, pull back a little, advance a bit further. This prevents the burr from digging into one single spot for too long, which helps reduce heat generation and significantly minimizes the risk of the burr getting lodged or stuck.
And this pecking motion, this controlled advance, leads us back to those strict time limits you mentioned earlier, which are primarily for safety.
Yes, absolutely critical. The very first ablation run, when you initially engage the lesion, should be extremely short, maybe only 3 to 4 seconds long. This is just a check for any immediate major complications like slow flow or the patient having sudden pain or instability. After that initial test, the total ablation time during any subsequent single continuous run should never, under any circumstances, exceed 20 seconds. That's a non-negotiable hard safety limit. It's designed primarily to prevent excessive thermal injury to the vessel wall and also to minimize the downstream shower of debris particles.
That 30-second limit seems directly connected to our earlier discussion about friction, heat, and debris. So what's the immediate crisis protocol if the operator sees or hears a major technical failure during a run?
Okay, red alert signs are: if the RPM suddenly drops sharply, we're talking by more than 5,000 RPM, that indicates a stall or excessive friction.
Or
If the operator hears a sudden harsh grating sound coming through the system. Or clinically, if the patient suddenly reports severe chest pain or their blood pressure plummets. Any of those means stop. You must instantly retract the burr back into a safe, lesion-free area of the vessel, usually just inside the guiding catheter, while maintaining the rotational speed briefly during retraction to prevent lodging. Once the burr is clear of the lesion, you cease rotation completely. Then you immediately perform angiography and jet contrast dye to check for potential complications like dissection, perforation, or the no reflow phenomenon.
okay, assuming that initial pass goes cleanly, what's the typical post-ablation strategy? Do you just do one pass?
No, not usually. After the burr successfully passes completely through the lesion for the very first time, you retract it immediately, without doing any further ablation on that pass. You then typically perform additional runs, often maybe 3 to 4 more times. These are sometimes called polishing runs. The key metric for success during these polishing runs is that they must feel completely smooth. The burr should pass back and forth through the now modified lesion, meeting absolutely no resistance.
How do you definitively confirm that you've achieved sufficient lesion modification before you commit to putting in the expensive stent?
Post-RA assessment is critical, you're right. The best way is by using intravascular imaging, usually IVUS. You can sometimes perform the IVUS assessment using the rotowire itself if you have a compatible system. Or, more commonly, you'll exchange the rotowire back out for a standard coronary wire using a microcatheter and then perform the IVUS assessment over the standard wire. If the IVUS confirms that the calcification has been adequately cracked or sufficiently excised, allowing for good potential stent expansion, then you proceed to stenting. However, if the IVUS shows modification is still insufficient, or if you try a test balloon inflation and it still doesn't expand the lesion properly, then you must repeat the RA. Usually this means stepping up to the next larger burr size and doing more polishing runs.
And what if the burr just won't pass at all during that initial attempt, even with pecking? What are the main technical options the operator has before potentially having to give up on RA for that lesion?
There are 2 main fallback strategies described. The first option is simply to downsize. Use a smaller burr than you originally planned. Try to create just a small pilot channel first with a smaller burr. If that's successful, you might then be able to go back and reattempt passage with the originally intended, slightly larger burr size, which now has a path to follow. The second option, which is perhaps a bit more advanced, is to try increasing the rotational speed, but only up to a maximum of about 190,000 RPM. You do this without changing the burr size. The idea is to leverage sheer speed, potentially, to overcome minor resistance points that were stalling the bow at the standard speed.
Okay, moving into procedural pitfalls. Rotational atherectomy is clearly a precision procedure, and mistakes or pitfalls can lead to pretty devastating complications. Let's delve into the really essential rules of engagement, the absolute must-nots for the operator during the procedure. What is the fundamental rule that dictates when the burr can and cannot be moved?
This rule is absolutely paramount. It's directly tied to preventing the most feared mechanical complication, which is the lodged or entrapped burr. The rule is, the burr catheter must only be advanced or retracted when the burr is actively rotating at a blading speed. If the burr stops rotating while it's within the lesion or even just slightly distal to the lesion, and you then try to pull it back or push it forward, the diamond tip will almost certainly dig into the calcification, risking immediate lodging. Rotation enables movement through the tight spot.
And what about the opposite? Rotating the burr, but without moving it back and forth? Is static rotation allowed for any length of time?
No, you must absolutely avoid rotating the burr in the same stationary position for any prolonged period. Think seconds, not minutes. Doing so generates massive localized heat due to friction. This can cause severe thermal injury to the vessel wall right at that spot. And perhaps even more alarmingly, the intense friction and heat in one place can actually damage and potentially even fracture the underlying guide wire. So keep it moving with that pecking motion.
So linking back to the RPM, drop that major sign of friction or stalling. What's the mandated reaction concerning both movement and rotation if that happens?
Right. If the RPM stops suddenly or drops sharply by that 5,000 plus RPM threshold, you must halt advancement immediately. That prevents the burr from getting jammed further in. And crucially, you must also cease rotation immediately. Stop pressing the pedal. Why? Because if you maintain rotation while the burr is stalled or stuck, it will literally grind itself deeper into the calcified lesion, making subsequent retrieval exponentially harder, maybe impossible without surgery.
Stop advancing, start rotating. Got it. And what about changing the speed setting, the RPM, in the middle of an active ablation run? Is that ever done?
No, the rotation speed must never be changed during an active RA run. The stability and the predictability of the cut, the way the burr behaves, depend entirely on maintaining a consistent RPM throughout that run. You set the speed beforehand during the D-draw test and stick to it for the run.
We mentioned earlier a seemingly minor setup detail regarding the Y connector, the hemostatic valve on the guiding catheter. Why is that specific small detail actually important for RA?
It seems small, but it matters. Over-tightening that Y connector where it seals around the burr catheter shaft as it enters the guide catheter, well, it can subtly compress the shaft and interfere with the free back and forth movement of the burr catheter. The operator only needs to tighten that Y connector just enough to prevent blood from leaking back out around the shaft. You shouldn't crank it down super tight. This smooth mechanical interface is really essential for allowing that gentle pecking motion to work properly without added friction.
Okay, now let's turn to what you called the ultimate technical nightmare.
Yeah.
The critical wire burr contact warning. What is the specific segment of the rotowire that poses this unique and severe threat?
Yes, this is a potentially life or death detail for the procedure. The rule is, the rotating burr must never, under any circumstances, come into contact with the radiopaque distal tip of the rotowire. This is that specialized coiled segment right at the very end of the wire, typically about 2.2 centimeters long, that's designed to be visible under fluoroscopy so you know where the wire tip is.
Why is contact with that specific coiled section so much more dangerous than, say, the burr contacting the main smooth shaft of the wire further back?
It's because that coiled tip has a significantly different diameter and a very different surface profile compared to the smooth, uniform body of the rotowire shaft. If the spinning burr touches that coiled section, the differential diameter combined with the immense frictional force generated at those incredibly high RPMs can instantaneously cause severe damage to the wire itself. It can unravel or fracture. Or perhaps even more commonly and immediately catastrophic, it can cause the burr to become instantly and often irrevocably lodged or entrapped on the wire within the artery. This single point of failure burr hitting the wire tip is unfortunately often the reason a procedure that was going okay suddenly turns into a major surgical emergency. Avoiding it is paramount.
Right. Let's transition to managing complications when they do happen. Despite flawless technique, as the source notes, complications can and do occur in rotational atherectomy. We really need to thoroughly understand the immediate management protocols for these high-stakes events. Let's start with arguably the most common one, the slow flow or no reflow phenomenon.
Yes, this occurs relatively frequently. The incidence figures cited in the literature vary quite a bit, but typically range from about 2%, maybe up to 20% of RA cases, depending on complexity. The three main mechanistic causes are usually thought to be: first, coronary artery spasm, just irritation from the procedure; second, a frank dissection of the vessel wall caused by the burr; or third, distal embolism, where debris, perhaps slightly larger than those ideal 5 mm particles, or maybe an aggregation of particles, causes a blockage in the tiny vessels downstream.
Okay, so if the operator sees the blood flow in the artery slow down dramatically or stop altogether on the angiogram, what's the immediate management sequence?
First step is always to pause the RA procedure immediately. Then you need to try and diagnose the probable cause via angiography. Is it spasm? Is it dissection? Is it likely embolism? While sometimes, maybe rarely, it resolves spontaneously, the standard pharmacological treatment involves injecting powerful coronary vasodilators, drugs like nitroglycerin or verapamil, directly into the coronary artery through the guiding catheter to try and relax any spasm. If that doesn't work, or if embolism is suspected, the operator might attempt a very brief, low-pressure inflation with a small balloon distally just to try and manually push the flow forward or break up any potential microemboli.
And the source article explicitly connects this slow flow phenomenon directly to periprocedural myocardial infarction, or PMI essentially, a small heart attack during or right after the procedure. What's the practical implication of that link for the patient?
The link is definitely strong. Experiencing slow flow significantly increases the risk of having a PMI, detected by a rise in cardiac enzymes. Interestingly, though, the data presented suggests that PMI that occurs specifically after RA, while obviously concerning and needs monitoring, may not negatively impact the patient's long-term clinical outcomes quite as much as initially feared. However, it absolutely does increase the frequency and severity of adverse events while the patient is still in the hospital, so it demands very careful monitoring and management in the short term.
If the slow flow situation is resolved and blood flow is restored, how does the operator then approach completing the rest of the RA procedure safely?
If blood flow does improve back to normal or near normal, the operator must treat the remainder of the procedure as being particularly high risk. They can't just carry on as before. This usually means dramatically shortening the burr rotation time for any remaining ablation runs. You keep those cycles extremely brief, maybe just a few seconds each. And the focus shifts entirely to completing the necessary lesion modification as quickly and as smoothly as possible, minimizing any further potential for spasm or embolization. Get the job done efficiently and get out.
Okay, next serious complication, coronary artery dissection. That's a tear in the lining of the vessel wall. What's the typical prevalence of that with RA?
The incidence is generally reported somewhere between 3% and 7% globally. The Korean ROCK registry, which is specifically focused on RA outcomes, reported it occurring in 6% of their cases, so not uncommon. The critical thing here is that the management decision whether you continue RA or stop is entirely determined by the severity of dissection, and operators typically use the NHLBI classification system to grade that severity.
Right, the NHLBI classification. Can you briefly contextualize that for us conversationally? Which types of dissection might allow the operator to continue, and which ones absolutely demand they stop RA immediately?
Sure. The classification basically runs from type A, which is just a minor flap or tear, all the way up to type F, which represents a major dissection causing complete vessel occlusion. Generally speaking, if the operator encounters what are classified as types A, B, or C dissections, these are usually more localized, minor tears that don't significantly impede blood flow. They may choose to carefully continue the RA procedure. The rationale there is often that the subsequent stent placement, which is planned anyway, will effectively seal or tack up that flap immediately afterwards. However, and this is crucial, if the operator encounters types D, E, or F dissections, these signify extensive, often spiral dissections, or dissections that severely impede or completely occlude blood flow, then RA must stop instantly, no question.
And if RA has to be stopped because of one of those severe dissections, what is the action plan then?
The focus shifts entirely away from ablation and towards restoring and maintaining blood flow. If the burr had already successfully passed through the lesion before the dissection occurred, then the priority is usually prompt balloon dilatation, followed by stent insertion to secure the vessel and seal the dissection. However, if blood flow doesn't improve with those measures, or if the burr was still proximal to the lesion when the severe dissection happened and flow remains poor, well, then the procedure often has to be abandoned entirely. And emergent coronary artery bypass grafting, CABG surgery, must be seriously considered.
Okay, now for probably the most immediately life-threatening complication, coronary perforation, a hole punched right through the artery wall.
Yes, perforation, Although thankfully rare reported incidence is somewhere between 1% and 4% is absolutely catastrophic when it happens. The ROCK registry specifically put its incidence with RA at 1.9%. It usually results from one of three main technical failures. Firstly, using an excessively large burr relative to the vessel size. Secondly, attempting RA in a severely angled or extremely tortuous segment where the burr might easily deviate. Or thirdly, and critically, continuing ablation after a severe dissection has already occurred, weakening the vessel wall integrity.
When a perforation is identified on the angiogram, what is the immediate life-saving management sequence that needs to kick in?
Speed is absolutely everything here. First, you must swiftly remove the rotating burr from the artery. But, importantly, you try to maintain the rotowire's position across the lesion. If possible, don't lose your access. Second, simultaneously, someone needs to immediately prepare for pericardiocentesis. That's the procedure to drain fluid or blood from the sac around the heart. Why? Because cardiac tamponade, where the heart gets squeezed by accumulating blood and can't pump, is the immediate life-threatening danger from perforation. The subsequent treatment then generally follows standard protocols used for managing perforations during any PCI procedure. Typically, this involves using a balloon catheter inflated across the perforation site to temporarily tamponade or plug the hole. This is followed by the rapid insertion of a specialized covered graft stent to permanently seal the rupture.
Electrical disturbances can also be a risk during RA. Why does this procedure sometimes cause bradycardia, slow heart rate, or even AV block, a disruption in the heart's electrical signaling?
It happens because the physical vibration from the high-speed burr, potentially some localized heat generation, or maybe even a shower of micro debris, can irritate or temporarily stun the heart's delicate electrical conduction system. The risk is significantly higher when you're ablating lesions located in vessels that directly supply blood to key parts of that conduction system. Specifically, that means lesions in the right coronary artery, which often supplies the SA and AV nodes, the left main coronary artery, the proximal part of the left anterior descending artery, or a dominant left circumflex artery.
Given that risk, is a temporary pacemaker routinely placed for every single RA procedure just in case?
Generally, no, it's not considered necessary routinely. The data from the ROCK registry, for example, showed that only about 3.3% of RA cases actually required a temporary pacemaker insertion. That's because the AV block, or the bradycardia induced by RA, is often very transient, lasting only seconds or minutes. It frequently responds well to simple mechanical maneuvers, like asking the patient to cough vigorously, which can stimulate the heart rate, or it responds quickly to drugs like atropine or aminophyllin. The main procedural adjustment, if temporary AV block does occur during an ablation run, is simply to shorten the subsequent ablation cycles even further. Aim for really rapid bursts of maybe just 3 to 5 seconds each, allowing the conduction system to recover in between.
Okay, finally, in this complications section, let's discuss the scenario you earlier called the rotational atherectomy nightmare, the lodged ER. Can you define that clearly and remind us of the incidents?
Yes, the lodged burr basically means the burr has become completely stuck, physically entrapped within the calcified lesion, and it cannot be advanced further or, more critically, retreated back into the guiding catheter. It's jammed. Thankfully, the incidence is low, reported around 0.5% to 1% of cases, but when it happens, it requires a very structured, often escalating emergency protocol.
What is the absolute non-negotiable first action the operator must take the instant they realize the burr is stuck?
Not press the rotation pedal. Stop all rotation immediately. That's rule number 1, 2, and 3. Continued rotation while the burr is lodged will cause it to dig deeper into the calcium, potentially severely damaging the rotowire shaft trapped inside it, and making eventual removal nearly impossible without resorting to open heart surgery.
Okay, rotation stopped. What is the initial management attempt to try and free it non-surgically?
First, pharmacologically, you can try injecting potent vasodilators like nitroglycerin down the guide catheter, hoping to relax any vessel spasm around the burr. Mechanically, the operator attempts retrieval by firmly holding both the external part of the burr catheter and the rotowire together as a single unit and applying gentle but strong, steady traction to try and pull it back. There's a critical note here. The operator must be extremely careful during this forced retrieval attempt to ensure the guiding catheter itself does not get pulled too deeply into the coronary artery, which could cause dissection or other damage at the vessel opening.
And if that initial direct pull attempt fails, what's considered the second-tier technical solution or trick?
The second technique, which sounds counterintuitive but is often surprisingly effective, is to try and insert a second standard 0.014-inch coronary wire alongside the stuck burr system down into the artery past the lodged burr if possible. The idea is that this second wire can sometimes act like a wedge or create just enough of a microgap between the entrapped burr and the surrounding calcified lesion, potentially allowing the stuck burr to then slide out with renewed traction.
Okay, and if both of those methods fail, we reach the most advanced, probably highest risk technical maneuver described in the source. This one involves using special equipment and actually cutting part of the RA system itself. Can you walk us through that process, the one requiring cutting the rota shaft?
Right, this is pretty much the final interventional attempt before deciding on surgery. It requires having an extension guide catheter, readily available devices like the GuideLiner or GuideZilla. The operator must first carefully cut the main rota shaft, that's the plastic tubing part of the system that's outside the patient, and remove the outer plastic covering, exposing the central drive shaft connected to the burr. Then, the extension guide catheter is advanced over the exposed rota system, as close as possible down the guiding catheter, towards the point where the burr is lodged inside the artery. The absolutely crucial step is then to attempt retraction by pulling back on both the extension guide catheter and the entrapped burr system simultaneously, as a single unit, ensuring firm contact between the tip of the extension guide and the back of the burr for maximum stability and support. This aims to maintain alignment and provide a rigid conduit to help retrieve the burr, often requiring considerable steady tension. If this advanced method also fails, then unfortunately the patient must be prepared for emergency ABG surgery to remove the burr and bypass the blockage.
Let's move into the final section, looking at RA in some special, perhaps less common situations. RA is usually employed for stenotic or significantly narrowed vessels. But what role, if any, does it play in a really complex landscape of chronic total occlusion or CTO? That's where the artery has been 100% blocked, usually for months or years.
It's a good question. The data suggests that about 7% of patients undergoing RA actually have CTO lesions. And importantly, the outcomes in these CTRA cases seem to be broadly comparable to RA performed in non-CTO lesions, which is definitely reassuring regarding safety. However, the indication for using RA in a CTO is very specific.
Okay, so when is RA indicated in a CTO patient? It's not used to actually drill through the blockage initially.
No, exactly. It's generally not used as the primary tool to cross the CTO itself. That usually requires specialized wires and techniques. RA comes into play after the primary challenge of crossing the occlusion. Getting that initial guide wire through the microchannels within the blockage has already been achieved successfully. RA is used when, despite getting a wire across, subsequent standard equipment, like balloons or stents, simply cannot pass through the channel that's been created because of extremely dense, heavy calcification within the body of that chronic occlusion. RA is used then to modify and enlarge that newly created channel.
Okay, so getting the initial guide wire across is still the biggest hurdle in CTO PCI. Once that's done, what's the greatest subsequent challenge specifically related to actually executing the RA part in a CTO?
The biggest challenge then is often just advancing the relatively stiff rotowire itself, safely and effectively, to the distal end of the vessel, through that often very tight, tortuous, and long channel within the CTO segment. To maximize the chances of success, the operator usually needs to insert a supportive microcatheter as deeply as possible into the lesion first. Then, they advance the rotowire through the microcatheter very gently and very slowly, feeling for resistance. In these complex CTO cases, either the rotowire floppy or the rotowire extra support can potentially be used, although the added stability and pushability of the extra support wire is frequently beneficial here. Some operators might even use a specialized screw-type microcatheter, like a teleport or a tornus, to help gently guide the rotowire through particularly resistant segments.
And the source emphasizes an extremely important safety warning regarding something called subintimal passage during the initial wire crossing in CTOs.
Yes, this is absolutely critical. If the initial guide wire passage, the wire that first crossed the CTO, even briefly deviated into the subintimal space, meaning it traveled between the layers of the arterial wall, rather than staying within the true lumen, then performing RA through that channel is strictly not recommended. It's considered very high risk. Why? Because the integrity of the vessel wall in that subintimal tract is already compromised. Using a high-speed rotating burr in that space carries an unacceptably high risk of causing immediate coronary artery perforation.
Okay, let's discuss another tricky scenario. What happens if the rotowire fails to reach the far distal part of the vessel? You told us earlier that RA is safest when the wire is positioned far distal to the lesion as it helps stabilize the whole system. What if that ideal positioning just isn't possible to achieve?
That's right. Distal wire placement is definitely the safety rule and the ideal. However, there are occasional clinical exceptions where you might proceed cautiously without perfect distal placement. Sometimes the inability to get the rotowire fully distal is only temporary, or perhaps the main blockage is really just concentrated at the very beginning of the lesion, what's often called the proximal cap of the calcification. In such cases, simply using RA to break or modify only that resistant proximal cap might be sufficient. If that allows subsequent standard balloons and stents to then pass and engage the rest of the lesion, you might still achieve overall procedural success, even if the rotowire itself never made it all the way to the distal end. It's a judgment call based on the anatomy.
What if the rotowire was correctly positioned distally initially, but then during the actual RA run, the operator notices on fluoro that it has slipped back, retracted towards the guiding catheter?
If the rotowire retracts or slips back significantly during an ablation run, the safety rule generally mandates that you must stop. You then usually have to remove both the rotowire and the burr system together from the patient. You would then need to reestablish distal wire position, perhaps using a microcatheter again, before reintroducing the RA system. You don't typically try to continue ablating with a retracted or significantly slipped wire, as you lose that crucial distal stability.
But the source mentions there is a specialized maneuver, a technique, to try and reposition the rotowire distally without requiring the entire laborious removal and replacement procedure. It's called the break defeat technique. This sounds highly technical. How does it work?
It is quite technical, yes, and requires careful execution. It's essentially a method for selectively advancing only the wire, without moving the burr forward at the same time. First, the operator needs to position the burr itself in a safe, lesion-free area of the vessel, often just inside the guide catheter. Then, they idle the burr at a very slow dynaglide speed, around 60,000 RPM. The key step is then pressing the brake defeat button on the advancer console. This temporarily delinks or disengages the mechanical lock between the burr rotation advancement mechanism and the wire drive system. While keeping the burr itself completely immobile in that safe zone, the operator can then gently advance only the rotowire forward, sliding back into the desired distal position. It's essentially a mechanism to quickly regain distal wire control without having to go through the time-consuming process of total system disassembly and reassembly.
Okay, our final special situation addresses a really challenging scenario. Dealing with failed stenting. Specifically, using RA to actually ablate an existing, previously placed stent that is found to be underexpanded, usually because it couldn't fully open due to severe underlying calcium that wasn't adequately treated beforehand.
Yes, this is an unfortunate but sometimes necessary situation. It arises when the initial lesion modification, perhaps done with just balloons, was inadequate. The stent goes in but can't expand properly against the rigid calcium. This leads to ongoing symptoms for the patient, or at least a very high risk of in-stent restenosis down the line. The solution, when deemed necessary, is quite aggressive. It involves using a relatively large-sized burr to deliberately ablate the metallic structure of the existing underexpanded stent itself.
Wow. How does ablating a metal stent differ, mechanically and perhaps even orally, from ablating native calcified tissue?
It's definitely a rougher job, as you might imagine. It generally takes a longer overall ablation time compared to ablating native calcium. And the operator will typically hear and feel through the system a rough, unmistakable metallic scraping or grinding sound. This sound, while perhaps alarming, is actually expected and considered normal during stent ablation. The key is monitoring. As long as the burr's rotation speed remains stable, the patient remains hemodynamically stable, good blood pressure, and they aren't reporting significant chest pain, the ablation can be carefully continued until sufficient modification of the stent and underlying calcium is achieved.
And what's the final confirmation step before attempting to insert a new, hopefully correctly sized and fully expandable replacement stent inside the ablated one?
Before deploying any new stent, you absolutely must confirm that sufficient modification has been achieved. This is best done using IVUS imaging to visualize the result inside the ablated stent. Alternatively, or additionally, you'd confirm by ensuring that a standard, appropriately sized balloon can now fully expand without any waste or restriction at the site of the previously underexpanded stent. You need proof the problem is solved before putting in more metal. It's also worth noting, as the source does, that while rotational atherectomy is the primary tool discussed here for this indication, another technology called coronary lithoplasty, which uses sonic pressure waves to fracture calcium, is recognized globally as a viable and sometimes preferred alternative for treating these challenging underexpanded stent situations.
Well, this deep dive into rotational atherectomy, A to Z, has certainly revealed a procedure that is really at its core, a highly sophisticated application of mechanical physics, hasn't it? It's transforming how we approach difficult cardiovascular interventions. It seems very clear that RA is no longer just an optional tool in the toolbox. It's rapidly becoming a fundamental, almost mandatory skill set for interventionalists who are navigating this increasing complexity of severe coronary artery calcification we see today.
Absolutely. And the success, as we've heard throughout, really hinges entirely on technical familiarity, meticulous preparation, and operator mastery. I think the key takeaway, the big shift described in the source, is moving away from that old philosophy of aggressive debulking towards this more strategic, controlled lesion modification, aiming for that sweet spot, that perfect zero point 0.4 to zero point 0.6 per artery ratio. That's the philosophical change that has ultimately made RA both safer and more effective in the modern era.
And for you, the listener, the key thing to grasp is that the technical preparation, knowing things like the DRAW test by heart, adhering strictly to that 30-second maximum ablation limit, is actually just as important as knowing how to handle the inevitable curveballs when things go wrong. Mastery of those emergency protocols we discussed, especially the very structured, often nerve-wracking three-tier management strategy for the incredibly complex lodged burr scenario, well, that's really what separates a competent operator from a true expert guide in these challenging procedures.
That foundational knowledge, covering both the routine steps and the potential complications, makes all the difference in ensuring the optimal function of our modern stenting technology. And ultimately, it's about maximizing patient prognosis, especially in these highest-risk cases where standard approaches might fail.
And that brings us nicely to our final thought for you to consider, something inspired by the sheer genius of RA's core mechanism. We heard how the principle of differential cutting relies on selectively filing away inelastic hard tissue while automatically sparing the adjacent elastic soft tissue, and it does this while breaking the waste material down into those safe, predictable 5-micrometer particles. So given this incredible level of precision microabrasion technology, what future medical or perhaps even surgical applications might utilize this very same differential cutting principle? Where else outside of cardiology could selectively removing hard tissue while preserving soft tissue be the key to minimizing collateral damage and improving outcomes?
Fascinating question. Definitely something to ponder next time you hear about advances in medical technology and material science.
Thank you for watching The Funnel Effect.